Hello everyone. So today we'll be discussing about introduction to retinal detachment, and we'll be talking mainly about one topic, Rhegmatogenous retinal detachment, which is very important long answer in ophthalmology UG MBBS exam. So coming to the posterior segment, posterior wall of the eye, you have these structures. So you have your vitreous humor, and behind the vitreous humor you have your retina. Retina is made up of two layers, that is your neurosensory retina and the retinal pigment epithelium. Behind that you have your choroid and sclera. Okay, so what is retinal detachment? So retinal detachment, according to American Association of Ophthalmology, defines as when subretinal fluid accumulates between the neurosensory retina and retinal pigment epithelium. You can see here clearly the neurosensory retina is detached from the retinal pigment epithelium due to accumulation of subretinal fluid. So that will lead to disruption of the photoreceptor function and consequential vision loss. So photoreceptors will be dysfunctioned and vision loss will be there. That is your proper definition of retinal detachment. Coming to the types of retinal detachment, so you have predominantly three types. That is your Rhegmatogenous retinal detachment. In this, you will predominantly see a retinal tear. Then, exudative retinal detachment, that is due to some causative pathology inside the eye, that will lead to detachment of the retina. And then you have something called tractional retinal detachment. This is your vitreous cavity. It has vitreous. So you have a tractional membrane, or either the vitreous itself creates some traction that will lead to suction of the neurosensory retina. That will lead to detachment of the neurosensory retina from the retinal pigment epithelium. That is your tractional retinal detachment. And then you have combined rhegmatogenous and tractional retinal detachment. You have the retinal tear and you also have the tractional membranes. Coming to the key risk factors for retinal detachment. So you have predominantly three types, right? Rhegmatogenous, tractional and exudative. I'll discuss the rhegmatogenous later. We'll see the tractional and exudative. So all proliferative lesions like proliferative diabetic retinopathy or some ocular trauma causing proliferative vitreoretinopathy and some vascular lesions like retinal vein occlusion, sickle cell retinopathy, retinopathy of prematurity, and extensive retinal neovascularization, that will lead to creation of a tractional membranes. So that will lead to tractional retinal detachment. Coming to the exudative, that is your serous retinal detachment, it has some causative pathology. The causative pathologies include some ocular inflammatory diseases like Vogt-Koenigsegg Harada syndrome or choroid tumors or vascular abnormalities, systemic diseases like malignant hypertension, preeclampsia, some infectious and infiltrative diseases and causes. So this will lead to serous, that is your exudative retinal detachment. Now, coming to the rhegmatogenous retinal detachment proper. So it is associated with retinal break. Most important thing of rhegmatogenous retinal detachment is the retinal break. Through this retinal break, so let us understand this with the help of a diagram. So you have your posteriorly retinal pigment epithelium, anteriorly you have your neurosensory retina, and this neurosensory retina has got a retinal break. And through this retinal break, what happens? Your subretinal fluid will seep through. Your subretinal fluid will seep through. So this is your neurosensory retina, this is your retinal pigment epithelium. So this is your subretinal fluid seep through. So that will lead to detachment. So this is your rhegmatogenous retinal detachment. Coming to the etiology or risk factors of rhegmatogenous retinal detachment. So age is the most important risk factor. So older age individuals have more predisposition to retinal detachment. Next is your sex predisposition. Males are more affected than females in a ratio of 3:2. Then the most important thing is high myopes. High myopes is they have their power more than -6 diopter, which means their axial length is more than 26 mm. So you have anteroposterior stretching of your eyeball. Because of your anteroposterior stretching of your eyeball, that will lead to stretching of your membranes. That is your neurosensory retina and retinal pigment epithelium. That will lead to myopia associated retinal detachment. You need to remember one more important point, that in high myopes, the retinal detachment will come at younger age itself. Then some other causes like history of cataract surgery like aphakia and pseudophakia, and other retinal detachment regenerations like lattice degeneration. Lattice degeneration is seen in myopia. And snail track degeneration, white with pressure, white without or occult pressure, focal pigmental clumps, retinoschisis. and some ocular trauma or some senile posterior vitreous detachment. So vitreous will be detached from the retina itself. That is called senile posterior vitreous detachment. So old age related thing, family history, and some history of retinal tear or detachment in the fellow eye. So we have some differentials for retinal detachment like PVD, and this one, PVD and retinoschisis, regarding which we'll see in the differential diagnosis. Okay, so coming to the clinical features, the patient will have two phases, that is a prodromal phase and detached retina phase. So in the prodromal phase, the patient will initially present with dark spots or floaters kind of sensation. Dark spots or floaters in the patient's vision. So the patient will say like he's feeling some kind of cobwebs. Cobwebs is something like, spider web. So in this matter, he's, just having some, obstruction in the V field. Or else the patient might complain of some ring called V's ring. So this is your cobweb, right? This is your V's ring. V's ring usually occurs when you have your retinal attachment around the macula, right? And then some showers of black shadow, usually vitreous hemorrhage. So all these, the patient will have dark spots or floaters. And then there is something else called photopsia. So what is photopsia is? Photopsia is like sensations of light, flashing sensation of light. What actually happens is when you have a retinal detachment, usually due to think of some vitreoretinal adhesion. So you have your vitreal cavity, you have your retina. So when you are having some vitreoretinal adhesions, this vitreous will create a traction, right? The traction will lead to stretch of your retina. So that stretch of your retina will lead to generation of stimulus. So that stimulus will appear as flashing sensation. That is your photopsia. To write in exam, you can remember dark spots or floaters or photopsia. Then detached retinal symptoms. What are the symptoms? So loss in the field of vision. Obviously, in the early stage, it will be localized. Usually, if you see this retina, so if it is detached in this place, so that corresponding visual field will be lost. That's it. But in late stage, what happens? Total, that is, it progresses towards the macular area. You'll have total vision loss or total field of vision loss. And then sudden appearance of some black dark cloud or veil in their sensation. That is also one thing which is there. And then sudden painless loss of vision. That is also a risk factor. That is also a clinical symptom which is complained by the patient. Sudden painless vision loss sometimes you can see in retinal artery occlusions also. Yes, that is the one thing which you need to mainly concerned about in sudden painless vision loss. Okay, coming to the ocular examination. So when you examine the external eye, it will be obviously normal. Visual acuity will definitely be reduced. Visual field testing will reveal scotomas. So while you are checking for scotomas, you also need to check for color vision. Usually when patient is having scotoma, that indicates the older retinal detachment. Okay, that is what you need to remember, one thing. So you have seen here, right, the before you have seen like loss in the field of vision in the symptoms. Early stage it localized. As it progresses towards your macula, it increases. The same way scotoma will be there. Next is your intraocular pressure. If you do digital tonometry or followed by that some applanation or indentation tonometry, you get some 5 mm of Hg lesser. Pupil, Marcus Gunn pupil or relative afferent pupillary defect. So you do a distant direct ophthalmoscopy, you will not have proper red reflex which is seen in normal retina. You will have altered red reflex or grayish reflex. So if you do a slit lamp examination, next you go with slit lamp examination. So that is how you go, right? You examine the external eye and then you do some distant direct ophthalmoscopy. Then you take the patient to do slit lamp examination. And in slit lamp examination, what will you see? Anterior vitreous pigment cells or granules. You will not be seeing the anterior segment, but you will see the anterior part of your vitreous. So you will not see the anterior segment. If you see, this is the lens. So this is the anterior chamber. This is your vitreous, right? So you'll see this particular area. You'll see some pigmented cells or granules. That particular thing is known as Schaffer's sign or tobacco dust, which is very important. It appears as a form of tobacco dust. That is why it is called as tobacco dust. Then the most important thing is your indirect ophthalmoscopy with scleral indentation. What is scleral indentation is you put some pressure over the eyeball. So that will lead to pressure over the sclera. That will lead to some retina getting attached to the posterior layer of your retina. So that will lead to proper clinical findings. Sometimes when you can see in this image, sometimes you are not clear in this area. You are not clear how it appears, right? This area, how it appears, you're not clear. But sometimes when you do that scleral indentation, you'll be able to see well. Coming to the freshly detached retina. So freshly detached retina, you'll see a gray reflex. Obviously, you can see the grayish color, right? Or else the normal retina appears reddish color. Next, convex configuration. Convex configuration in the sense it appears like a bubble, like it's like bulging out, bulging towards you. So it appears convex. And the most important thing is characteristic corrugated appearance. You can see the corrugations in this image, right? Can you see the corrugations? Corrugations are clearly seen, right? And then undulates with eye movements. Undulates with eye movements is the most important factor which differentiates it from tractional retinal detachment. The tractional retinal detachment, it does not undulate with eye movements, it undulates with eye movement. That is, this particular, it is like floating in water. It moves with eye movements. That's what you can remember. Next, coming to the retinal vessels. How do the retinal vessels appear? They appear as dark tortuous spots which oscillate with retinal movements. So they will also be oscillating with retinal movements. They are dark tortuous spots. Then retinal breaks. This is the most important diagnostic thing for Rhegmatogenous retinal detachment. They may be in the form of retinal tears or retinal holes. Most commonly if this is your right eye, in the upper temporal quadrant is where we see. Then retinal tears. So retinal tears are mostly horseshoe shaped or arrow shaped. So horseshoe shaped or arrow shaped, they are in the form of like this. Or you have something called anterior retinal dialysis or giant retinal tear. Then retinal holes. In retinal holes area, you'll have chronic atrophy of the sensory retina. The neurosensory retina, which has detached, will undergo chronic atrophy. You will see reddish, round or oval kind of lesions. Okay. Old retinal detachment. In old retinal detachment, you will see retina will be thinned at that area and subretinal demarcation lines and secondary intraretinal cysts. You can see, Okay, wait a minute. Yeah, you can see here clearly. So this is your old detached retina. Next is your total retinal detachment. So total retinal detachment is something which is really interesting. If you see, you'll have this is funnel shaped and being attached only at disc and macula. How does it create a funnel shape? So you can see here, you can see a funnel shaped retinal detachment. How does it happen? So let me explain. So think of this is your retina and this is your macular area and this is your neurosensory retina. So it is being attached only at the disc and the macula, right? So it is attached only at the disc and the macula. So remaining whole of your neurosensory retina is detached. This is your neurosensory retina, this is your retinal pigment epithelium. Now it is created like a tornado kind of, funnel kind of, no? So that is your funnel shaped detachment. So that is what you can see here. Clear, right? Clearly you can see some funnel. It is like something is sinking inside. Okay. Next is your most important one is your Linkoff's rules. Linkoff's rules are used to establish the site of retinal tear. So where the retinal tear has actually occurred. So first is your in superotemporal or supronasal detachment. So let us always take your right eye. So right eye. Okay. So this is your superotemporal or supronasal, okay, detachment. So the primary break is within 1.5 hours of the highest border. If this is your highest border of your break, the primary break will be 1.5 hours. 1.5 is your distension, like is it 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock. So if primary break is at 12 o'clock, it will be maximum within 1:30. So this is somewhere over here, right? You got it? 1:30, I didn't mean the minute hand, it's somewhere over there. If it is within the 1 o'clock, it will be somewhere near 2:30, 2.5 in this area. If the highest border is here, it will be like this. So that is what you need to understand. And the next thing is, in total detachment or superior detachments that cross the 12 o'clock meridian, that is vertically above the disc. So vertically above the disc and that cross the 12 o'clock meridian. So crossing the 12 o'clock meridian, you have some total, think of a big detachment like this. It is crossing the 12 o'clock meridian. So it forms a triangle. Triangle base will be at ora serrata. Ora serrata is your anteriormost part of your retina. If you take your globe, I am drawing here. So this wall will be your retina. So this will be your somewhere ora serrata, and the base will be at the equator, and it will extend from 11 o'clock to 1 o'clock. So it is crossing the 12 o'clock meridian. So it will extend from 11 o'clock to 1 o'clock, and it will extend up to the ora serrata. If you see in this view, this is your retina, ora serrata, and base will be at the equator. Next is your inferior detachment. In inferior detachment, the higher the side of detachment indicates the side of disc where the primary break lies. The break is found below the horizontal meridian. I think you can understand this by yourself. So if you want me, I'll explain this. Horizontal meridian, below it will be there, and the highest side of detachment. So that will be the side of the detachment. So this is your highest side, right? So detachment will mostly be in this quadrant. Then you have something called inferior bullous detachment. The primary break is above the horizontal meridian. So coming to the investigations. So you have done indirect ophthalmoscopy with scleral indentation. Now you will come to investigations, B scan USG. So when you are doing indirect ophthalmoscopy, you can observe something like media opacity, that is vitreous hemorrhage. This will preclude your fundus visualization. You cannot view the fundus properly. Then you cannot give any conclusive reports through your indirect ophthalmoscopy. Then what do? You do B scan USG. So B scan USG, the detached retina will be appearing as a bright, mobile, echogenic membrane. So it will appear as a bright, mobile, echogenic membrane which is tethered to optic disc but separated from the choroid. So it is attached to the optic disc area. So okay, let me draw with the help of an diagram. Yeah. So you have your choroid, right? And then think of this is your optic disc area, and this is your retina. So it is okay. Yeah. This is your retina. So it is attached to your optic disc area. Optic disc area, it is attached, but it is separated from your choroid. It is your choroid. This is your retina. So how does it appear? Bright, mobile, echogenic membrane. You can see like a membrane flowing in the USG. Then membrane's mobility and folding are best appreciated during kinetic examination. In what is kinetic examination? In kinetic examination, you ask the patient to move the eye. Okay. And the detached retina will undulate. I told you most important thing is your undulation of your retinal detached retina. That will remain anchored at the optic nerve head. That will remain anchored. Anchored means it will remain attached at your optic nerve head. At the optic nerve head, it will remain attached, but other areas it will undulate. That is very important. Next is your spectral domain OCT. Spectral domain OCT provides high resolution cross-sectional images to confirm neurosensory detachment, and it differentiates from its other differential diagnosis. Okay, you just as of now you just remember it differentiates from the other differential diagnosis. Then some ancillary testing you do. So why do you do ancillary testing? So ancillary testing is typically to exudative and tractional retinal detachments, where you need to find out the pathology, systemic pathology or ocular pathology. It can be systemic or some ocular pathology can be there. Then electroretinal retinography, that can be subnormal or absent. You need to represent this in your exam. Next is your differential diagnosis. This is the most important part of the whole lecture. So differential diagnosis are retinoschisis, choroidal masses, other retinal detachment, and serous retinal detachment. You know how to differentiate from other retinal detachment. So if you come closely to this image, so this is your retina. So this is your vitreous humor, again neurosensory retina, retinal pigmental epithelium, choroid, sclera. This is your retinal detachment. Neurosensory retina is separated from your retinal pigment epithelium, and you have accumulation of subretinal fluid. Retinoschisis. Retinoschisis is separation of inner and outer layers of neurosensory retina only. You can see the neurosensory retina itself has inner layer and outer layer which got separated. That is your retinoschisis. Then choroidal detachment is choroid is detached from the sclera. This is your sclera. Now choroid is detached. This is your choroidal detachment. Then detachment of the vitreous gel from the neurosensory retina. Before I was saying, no, senile posterior vitreous detachment. So this is what it happens. The vitreous has detached from the neurosensory retina. So this might create a tractional force that may lead to, again, retinal detachment. Okay. Next, central serous chorioretinopathy. You can see macular edema and some breaks in the retinal pigment epithelium that will lead to seepage and everything. So coming to the complications. Complications include proliferative vitreoretinopathy, complicated cataract when this retinal detached part gets attached to your lens matter. Uveitis and phthisis bulbi. You can remember as P cup. Complications are P cup. And DDs, you can just remember this diagram and you can just remember 1 1. So this will be your first, this will be your second, this will be your third in the order, right? This is detached first, then within the neurosensory detachment, then the neurosensory detachment from the pigment epithelium, then choroid and scleral detachment, then central serous chorioretinopathy. So that's how you remember. Coming to the treatment. Treatment is very important. So treatment goals are anatomical reattachment of neurosensory retina. So you need to attach the neurosensory retina back to your, so you have your neurosensory retina, you have your retinal pigment epithelium, they both need to get attached. And most important is your restoration of your visual function. Okay, what are your principles? So principles, okay, let me make it easy to remember for you with the help of a diagram. So this is your choroid. Okay, so in front of your choroid, what do you have? Retina. So think of, this is your retinal pigment epithelium, and then you have your neurosensory retina, and then inside you have your subretinal fluid, and then there is a break. So how do you treat? So you need to seal this retinal break. That is your first goal, first principle. Second principle is subretinal fluid drainage. Third one is chorioretinal apposition. Okay, I think this will be very easy for you to remember the principles with this example. So retinal break sealing, subretinal fluid drainage, and maintenance of chorioretinal apposition. Okay, next, coming to the treatment methods. So the most common method of treatment we use is retinopexy. So what is your retinopexy? So in retinopexy, what happens? So in this particular retinal detachment, what are the two defects you have? One is your retinal tear and one is your detachment. So you have your retina abnormal in that area. So what do you do is, in retinopexy, you create a scar tissue using, laser or using some some mechanical force. You create a scar tissue. So this scar tissue acts as welding, that will lead to attachment of your neurosensory retina to retinal pigment epithelium. That is retinopexy. So you can write this as definition of retinopexy. So the tears and detachments of the retinal detachment will be scarred. That will lead to welding of your neurosensory retina to your retinal pigment epithelium. Now coming to the treatment methods. Laser retinopexy. So laser retinopexy, you use laser, simple, right? Small localized detachments or breaks in which laser barricade can be easily performed without any interference with the patient's visual function. So small detachments, and this detachment, if you use laser, that will not cause any problem to your patient's vision. So, and it must also prevent the propagation of any other detachment. For that, you go with laser retinopexy, simple. Then pneumatic retinopexy. In pneumatic retinopexy, you usually do it for what kind of retinal breaks? Single or limited superior retinal breaks. So you have a single and superior retinal breaks, and the patient must be cooperative. And clear media. The media has to be clear. Your vitreous and anterior chamber. So why the patient needs to be cooperative, I'll tell you. So the point is, the procedure involves intravitreal injection of an expansile gas, that is either SF6 or C3F8. So this will act as a tamponade, and this tamponade will lead to some pressure buildup, and that will lead to some attachment of your neurosensory retina. You have your neurosensory retina, right? So neurosensory retina and your retinal pigment epithelium, this acts as a bubble and it will create a tamponade. And then followed by the tamponade, you can do cryopexy or laser retinopexy, and that will lead to proper attachment. But the point is, the patient needs to maintain his head position for about 3 to 4 days. So because of that, this is not that complaint in India. Then coming to the next most important is your scleral buckle. Scleral buckle is very important. Okay, I need some space. Okay, scleral buckle. So you have your eyeball. So think of this as your eyeball, right? So to your eyeball, you'll have externally, what are the attachments? You have your rectus muscles, right? So you take silicone bands and you permanently place behind this rectus muscles the silicone bands. So that will lead to this silicone band. That will lead to what? Scleral indentation. That will lead to some pressure buildup, and that will lead to something called scleral indentation. External indenting the sclera, and that scleral indentation will support your retinal tears. You have any retinal tear, no, that will be supported. And you are having any this side, this direction, this is just simple physics. If you are having this direction of some traction, no, so when you are having forces coming this side, the traction will be reduced. So vitreoretinal traction also will get relieved. Now it is opposing each other, the retina are opposing each other. Now you can do cryotherapy. It needs to be performed in operating room. So what are your indications for this? Young phakic patients, peripheral breaks, absence of significant proliferative vitreoretinopathy. Then other include, you can just for namesake, pars plana vitrectomy. You can use different needles. You cut out the vitreous stands using vitreous traction, and then you do drain the subretinal fluid, and then you allow the endolaser with internal gas candamponate, or to flatten the retina. Drain and flatten the retina. So you have a lot of indications. So all these are indications. Combined procedure for complex and recurrent cases. You can use buccal, you can use vitrectomy, you can use both anterior traction, posterior traction, everything can be there. So the most important thing is your pneumatic retinopexy and scleral buccal. I think you have understood how scleral buccal works. So prognosis, anatomical success will be more than 90% with modern surgical techniques. So macular status, if macula is gone, vision is gone. So that is the most important. And duration of retinal detachment, because when the retinal detachment is of chronic duration, the prognosis will be poor. Absence of proliferative vitreoretinopathy, early detection, prompt repair of strongest prognostic factors. So these are the differences between rhegmatogenous traction and accelerated detachment. We'll see in a different video. The most important thing you need to note is these two boxes. So rhegmatogenous retinal detachment is convex, but here it is concave, and it may be central or peripheral. It is gravity dependent corrugated appearance. The most important point is this one. It undulates with with movement of your eyes. The bulle or the folds will undulate with movement of your eyes, but it is taut. It does not undulate. So that's how you differentiate between rhegmatogenous and tractional retinal detachment. Thank you.